Welcome to another Puscast podcast to review the infectious disease literature with commentary for the first 2 weeks of August 2008. Remember, you can skip this intro, but who would want to? As usual, it's available on iTunes, and if you like this nonsense, my endless ego loves to be fed with glowing reviews on iTunes. This is brought to you by Pusware LLC, the publisher of the Puscast annotated compendium of infectious disease facts, dogma, and opinion, your Uber hyperlinked electronic guide to infectious diseases at pusware.com. This is CME accredited, so after you've listened, take the online quiz and get a half an hour of free CME, thanks to the Legacy Health System. Since it is CME accredited, I have to mention my conflicts of interest. I have no conflicts of interest. As always, this is a review of the infectious disease literature with snarky commentary. If you don't like snarky commentary, I suggest you listen to the Lancet Infectious Diseases. As usual, bits of business I need to do. We have a great residency program at Good Samaritan Hospital. If they tolerate me, they'll probably love you. Remember that the references are online, so remember that if you want the real skinny, you have to read the article yourself. As always, I would like to thank those who have supported this podcast and the financial pain of bandwidth, which I've been meeting. Thank you very much. Remember, though, that if you have been downloading this podcast for the first time, please don't download everything all at once because it puts a strain on my bandwidth, and there's nothing worse than a strained bandwidth. Finally, if you like this sort of nonsense, remember that I also do the Quackcast, a review of supplements, complementary, and alternative medicine, i.e. scams, available on iTunes. And I'm an occasional contributor to the Science-Based Medicine blog, available at sciencebasedmedicine.org. Remember, the world needs more Mark Crislip. And now, on to the literature. We'll start off with something near and dear to my heart, which is hand hygiene. And this article was entitled, Why Don't Doctors Wash Their Hands? And they looked at the thinking styles of physicians and their hand hygienes. And it's interesting that in this group of physicians, those that were rational thinkers were less likely to be hand washers, and those that were thinkers of the experiential automatic thinking type were more likely to wash their hands. This would suggest that using rational thought with physicians to get them to increase their hand hygiene compliance is the wrong way to go. Note in the movie The Dark Knight, the Joker washes his hands at the end of his interactions in the hospital with Two-Face, and the Joker is about as irrational as anyone you want to get. So this observational study of physician hand hygiene would suggest that more of our physicians need to behave like the Joker. One of the techniques used for determining whether or not patients are infected and trying to keep them out of various and sundry countries is cutaneous infrared thermometry, where they read the temperature off the forehead using an infrared gun. These are often used to screen large numbers of people, specifically looking to see if they are febrile, and if so, then they can shunt them back to their country of origin. The study looked at over 2,000 patients and compared infrared thermometry with the ear thermometry in patients and found that the problem is that it was a high proportion of false positives. If you use 38.0 as your cutoff, which is what I would use for determining whether or not someone is febrile, the sensitivity is 0.82, the specificity is 0.77, the positive predictive value is 0.1, and the negative predictive value is 99, with an accuracy of 0.78. Again, this was due to a high proportion of false positive rates, which makes using infrared thermometry maybe not the best way for screening, although you'd rather have a bunch of false positives than a bunch of false negatives under those circumstances. This may come as a surprise to some of you, but cocaine is not good for you. Now, this article looked at the use of crack cocaine, and as one comedian said, never take a drug that's named after your ass. But crack cocaine negatively impacted HIV in women. They followed 419 women over a period of time and found that those that used crack cocaine were 3 times more likely to die from AIDS-related causes. This includes patients who were highly compliant on their heart. Now, this is not a surprise. There is an interesting literature that suggests that cocaine particularly is bad on the immune system in lymphocytes. So this is more data to suggest that if you have to be a drug user and have HIV disease, the drug you don't want to take is cocaine. Might I suggest heroin? The preceding comment on heroin was sarcasm and should not be construed as favoring the use of illegal drugs by anybody at any time. This is in sharp contrast to the recent JAMA article that looked at outcomes in intravenous drug users and HIV disease and found that there was no difference in outcomes in HIV patients with or without the use of intravenous drugs. Now, crack, of course, is inhaled, not shot up, and usually it's meth and heroin that are more likely to be injected intravenously. The JAMA article does not break down their patients as to what their intravenous drug of choice was. But I think if you have to do drugs and have HIV, you're probably better off shooting up heroin than you are smoking crack. So what is the best initial therapy for a patient with HIV? Well, this particular study compared abacavir lamivudine versus tenofovir emtricitabine, and they could then either get efavirenz or atazanavir or ritonavir. And they followed them over time based on their HIV levels. And they found that patients who had higher HIV levels were more likely to fail if they were receiving abacavir. The failure rate was 2.33, about double the rate of those who were not on abacavir. So their conclusion from this study was that in HIV-naive treatment patients who were on abacavir-containing regimens, there was a higher virologic breakthrough than patients who weren't on a abacavir-containing regimen. The curious thing was the number of patients who had hypersensitivity was fairly high at 7%, and one poor guy died of reinitiation of abacavir, despite the fact that it's well known that if you have a hypersensitivity reaction to abacavir, you should never, ever, 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 never, 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 ever, 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 never, 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 ever, ever, ever re-challenge the patient. Never, ever, ever, never, and ever, 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 never, never. You got the picture there, guys? And fortunately, you can screen for abacavir hypersensitivity by checking their HLA type, as we have talked about in prior podcasts. Curiously, in this Medscape report, the GlaxoSmithKline analysis, i.e. the people who make abacavir, didn't believe the results. Water's wet, fire's hot. Drug companies don't believe data that contradicts their profits. One of the dumbass things that has marked HIV therapy during my career is the unwillingness to do susceptibility testing either for opportunistic infections or for HIV before instituting therapy. And that always has been shown that when you do susceptibility testing, you may get better outcomes. I quote from this article from Medscape, quote, patients infected with drug-resistant HIV generally have poor virologic outcomes on first-line heart compared to those infected with wild type. Earlier studies suggested that, get this, treatment response can be improved if resistance testing is performed prior to treatment, end quote. Water wet, fire hot. This study, they did just that. They did genotypic testing, tailored the initial therapy to patients, and found that their outcomes were the same. My God, you do susceptibility testing, you tailor your antibiotics, and you get a better outcome. What a concept. Man. And given that patients can have resistant virus even if they've never seen antiretroviral agent, it behooves everybody in a country that has a first-class medical industrial complex, which is no longer the United States, that you do genetic typing of your HIV before you initiate therapy. Big duh. The epidemiologic studies always make my head hurt because fundamentally I don't understand them. But this article, which was published in JAMA, looked at the estimation of HIV in the United States. They took a population of patients who were diagnosed with HIV and then extrapolated to the entire United States for the rough incidence of HIV in the country. They estimate about 55,000 new cases a year of HIV, about 45% in blacks and about 53% in men who have sex with men. They estimate that there have been about 55,000 cases a year from 2003 through 2006, and they think that the rates have leveled off in terms of yearly incidence of disease. So how many people get HIV every year in the U.S.? I'd say 55,000. I know there's debate as to the validity of these numbers, and my brain is too small to tell you if those debates are worthwhile or not. Just a brief report of azatanavir-induced ventricular tachycardia due to a prolonged QT. This is not the only drug that will prolong your QT. Quinolones and some imidazoles will do it as well. In this particular study, they blamed high-dose methadone as a concomitant medication to prolong the QT. But it would probably be a bad idea to put someone on fluconazole, ciprofloxacin, methadone, and azatanavir, unless, of course, you were the beneficiary of their life insurance policy. Again, not that I'm suggesting that. It's always the case that in the real world, diagnostic testing is never as good as what's published. In this particular case, they looked at the rapid HIV test in an emergency room, and this was published in the Annals this month. They had 854 patients who had rapid HIV testing. 39 were positive. 31 had confirmatory testing, and a paltry 5 turned out to be HIV infected. So this test is not that great when you consider that 5 of 31 patients had actual HIV disease. However, if you're using a screening test to, say, institute prophylactic therapy in the ER in someone who's had a blood and body fluid exposure, you probably want something that had a high false positive rate than a high false negative rate. But you should get the results of the rapid HIV and interpret them with a grain of salt substitute. And risk behaviors for HIV are probably more common than most people would suspect. This study looked at 2,357 heterosexuals, and they found that 18% of subjects had had anal sex in a 3-month interval, and 40% had had it in a year, and that 63% of these people never used condoms. So HIV risk factors are not uncommon in all sexually active populations, and people need to remember to use your damn condoms. What is the infectivity of HIV with heterosexual sex? Well, it's usually said to be about 1 per 1,000 sexual contacts. This article published in Lancet Infectious Diseases looked at a meta-analysis of all the articles on the topic and suggests that it may be much higher, in fact, by a factor of 100. Now, they estimate in this meta-analysis that anal intercourse would have 1 per transmission for every 3.1 contacts for penile anal sex, but it depends on stage of disease, circumcision, presence of genital ulcers, and other diseases. But they think that it may be closer to 8 transmissions per 1,000 sexual contacts from heterosexual intercourse. However, these numbers are so variable that I think the bottom line is wear your damn condom. But at a rate of 8 per 1,000 sexual contacts, it would take the average married male about 1,000 years to get HIV. There is a subgroup of people who believe that the MMR vaccine causes autism. It doesn't. But the results of this fear has led to a marked decrease in the use of the measles vaccine in some parts of the world, like, let's say England. And because of the lack of vaccinations in that country, they estimate that there are 3 million people in England who have not had their vaccinations. As a result, measles is going up. Last year in England and Wales, they had 1,726 confirmed cases of measles, more than the prior 10 years put together. And they estimate that they could have an outbreak that could lead to between 30,000 and 100,000 cases of measles. So that's the result of the anti-vaccine lunatics. People are getting measles again, and some kid's going to die from them. So 3 articles on rickettsia. I love rickettsia. They're a growing and interesting infection. The first is in Clinical Infectious Diseases, and they looked at African tick bite fever, which is Rickettsia africae, which is found in sub-Saharan Africa, and curiously the French West Indies, which is not part of Africa. And they looked at this disease in elderly people, because elderly people have money and they're traveling off to South Africa. And by gosh and by golly, they were getting African tick bite fever, and they were more likely to be symptomatic, to have severe symptoms, and to have more long-lasting general symptoms. So elderly patients in particular need to be careful when they go off to South Africa, because when they pick up rickettsia, they will be sicker than the average bear. By the way, tick bite fever in this part of the world, at least due to Rickettsia africae, tends to be a more mild rickettsial with fevers, rash, headache, malaise, but it's not a fatal illness like Rocky Mountain spotted fever or other tick-borne rickettsia. So you plan on spending your summer in Germany, trekking through the forest, drinking bratwursts, and eating good German beer. I know I got that backwards. Well, what are your risks of getting a rickettsia illness? Well, this guy looked at Rickettsia felis and fleas found throughout Germany. Rickettsia felis is another one of the rickettsiosis that was initially found in cats, but is found in a variety of other animals as well. In this particular study, they found Rickettsia felis in all the hedgehogs of Germany, and 9% of the cat fleas in Germany, and 1 in the hen flea. So, if you are in Germany and you see an edgeog, flee it, because its fleas have Rickettsia felis. And if they can't feed on the edgeog, they're going to feed on you. But Rickettsia felis is one of these zoonoses that we'll probably be seeing more of, especially once we have a diagnostic test that we can use routinely on clinical specimens. And finally, with regards to rickettsia, is a study out of Hong Kong that looked at risk factors associated with life-threatening rickettsial infections, and they found that a delay in empirical doxycycline was associated with worser outcome and a more prolonged hospitalization, as well as more organ dysfunctions. Interestingly, treatment with a fluoroquinolone and or clarithromycin did not correlate with clinical outcomes, even though I've always been under the probably incorrect assumption that quinolones are good for the treatment of rickettsial illnesses. Now, the East has different rickettsia than are found in Africa and the United States, primarily Rickettsia tsutsugamushi. God, I love saying tsutsugamushi. But if you suspect a rickettsial illness, the sooner you get doxycycline in the patient, we call these doxycycline deficiency states in infectious diseases, the more likely it is the patient will do betterish rather than worserish. So switching gears, how's about MRSA in the environment? This study came out of Boston and was a, quote, pilot study, unquote. What they did is they went to 35 homes in the Boston area and cultured a wide variety of surfaces in kitchens, bathrooms, and living areas looking for staph. Of the 35 houses, 34 had staph found in 1 or more areas. Okay, no big deal there. Now, the other thing is they found MRSA in 9 of 35 homes, which is about 1 1/4. And they found it in a wide variety of household surfaces. Sinks, countertops, faucet handles, dish and sponges, dish towels, tubs, and a pet food dish. Now, the interesting thing was they found a correlation, and correlation is not causality, between the presence of a cat and isolation of MRSA on surfaces. So it appeared that as these foul felines wander about your house in search of furniture to damage, they cart around MRSA with them and spread it through your environment. So my recommendation is if you have Staph aureus in your environment and you have a cat, your best bet is to autoclave your cats to get rid of the carriage state. Not unsurprisingly, when you have a patient who's colonized with MRSA, say in their nose, and you put them on antibiotics, say a quinolone or beta-lactam, the amount of MRSA in their nose goes up, but it goes up surprisingly. It goes up almost double the log, which is a lot. Going from a 2.5 log to a 5 log is a huge jump in the number of organisms. And also, as you give beta-lactams or quinolones, the MRSA in the local patient environment also goes up concomitantly with the increased load in the nose. So if you have a patient who's colonized with MRSA and you start giving them other antibiotics that don't get MRSA, you can expect, since each patient is sort of their own little Galapagos island of survival of the fittest, that the local nasal population of MRSA will increase, as will the local spread in the environment. As I've mentioned many times, I'm a tired old man, 357 in dog years. Now, back when I was a resident, we ruled out myocardial infarctions with CKs and LDHs, and these young whippersnappers with their troponin levels, I don't know what to make of these. Now, interestingly, this study looked at troponin levels in patients who were having endocarditis. All the patients also had TEEs. And interestingly, with this, having an elevated troponin was a bad prognostic sign. If they had elevated troponins, 18 of 35 patients had valve replacement or in-hospital death, as opposed to just 4 of 27 patients with normal cardiac troponins. That's 51% of patients had a valve replacement or died if they had an elevated troponin versus a paltry 15% with normal troponins. So troponins, if elevated, are a sign that something funky is going on in your patient's valve, and you better be paying attention. Just ordered one today on a patient, in fact. Don't know what the results are yet. It turns out that the country of Sweden has a huge registry of celiac sprue cases, and they have 15,000 people in this registry. And they do lots and lots and lots and lots and lots of manipulations to generate lots of papers in a lot of different journals, so that Dr. Ludvigsson, Ludvigsson, of Örebro University in Sweden, actually it's Örebro, Orebro, and he puts out tons of articles on this database. And it turns out that if you have sprue, you have an increased risk of sepsis, primarily due to pneumococcus, which they hypothesize is due to the hyposplenism of celiac disease. However, they found that the relative risks of sepsis are 2.6 in patients who have celiac disease compared to them what didn't. So celiac disease is a risk factor, though only small, for infections. So what's the best therapy for rhinocerebral mucor? Besides surgery? Well, probably, maybe, perhaps posaconazole. However, this study compared patients who received just a polyene antibiotic, i.e. amphotericin, versus those who received a combination of a polyene plus caspofungin. Now, caspo was not supposed to have any activity against mucormycosis. But in this study, 100% of the patients who received a combination of a amphotericin and caspofungin survived, whereas those that had monotherapy did not. Now, this was retrospective and so flawed on that case. But even though echinocannins are supposed to have no activity against mucor, in this particular study, those that received combination therapy had better outcomes than those who did not. So something to think about in patients who have rhinocerebral mucor, a horrible disease at best. As Hamlet said many times, or actually only said it once, TB or not TB, that is the question. Actually, Woody Allen said that in a movie. But this study looked at the effect of skin testing for TB on subsequent gamma interferon assays, i.e. the quantiferon gold. And they found that if patients were PPD positive and did not have a strongly positive quantiferon gold initially, if they repeated the quantiferon 2 to 4 weeks later, they were much more likely to have a positive quantiferon gold. So the TB skin test boosted, as it were, the quantiferon gold, whereas the patients who were PPD negative did not exhibit this effect. So if you have a patient with a positive PPD, trying to figure out if they truly have TB or not, that may boost them to make their quantiferon more likely to be positive 2 to 4 weeks later. By the way, drinking is associated with an increased risk of tuberculosis. They put the risk in this article as a 3-fold risk of active TB if the patient consumes more than 40 grams of alcohol per day. How much is 40 grams of alcohol? I wish they'd put this in terms of bottles of beer on the wall. Then I'd understand it. Who sings the song, 40 grams of beer on the wall, 40 grams of beer? Take one down, pass it around, get tuberculosis? Just not the song I want to sing at the bar. So as the 4 horsemen of the apocalypse get ramped up for the upcoming century, one of the things to worry about is XDR-TB. Wolverine and Storm had it, and now it's coming your way. This study looked at the results of therapies for XDR-TB in the New England Journal of Medicine and found that outcomes were surprisingly good. Patients in this study were HIV negative, They had directly observed therapy, and they got an average of 5 drugs, which is pretty good, including cycloserine and injectable anafluoroquinolone. Of these patients, there were 651 patients all in the study, 48 of whom had XDR-TB. Of these patients, 29 completed therapy and were cured, which was 60%. So if you have MDR or XDR-TB in this series, 66% of the MDRs were cured and 60% of the XDRs. However, if your cup is 40% empty kind of guy, you'd say that 40% of patients with XDR-TB weren't cured, which is a pathetic outcome for an infectious disease, but to be expected in a bug that one can't really kill. I'm surprised they got as good a results as they did. And now, what I think is one of the weirder articles I've ever read in my subspecialty. The word consanguinity. Do you marry your cousins? Well, this looked at the issue of consanguinity in couples and its result in tuberculosis. It turns out that about 60% of all marriages, as the article says, in many parts of Asia and Middle East and Africa, are due to close biologic relatives. The upside for this is if you have an alpha thalassemia, which is protective against malaria, you are more likely to have kids that are resistant to malaria. The downside, of course, is if you have fatal recessive genes, you're more likely to have dead children as a result. This study was based on computer models of genes in consanguineous populations, and I will just quote the conclusion because it's a hoot. Human inbreeding enhances the speed of fixation of recessive and codominant alleles. Consequently, the elimination of recessive-lethal alleles is increased by an excessive mortality of children in consanguineous populations, i.e., your children die more often of other diseases. However, an enhanced speed of selection of the codominant alpha thalassemia allele increases the relative fitness against malaria. When mortality from malaria is high, this increase in fitness could offset the loss of life resulting from inbreeding. Therefore, consanguinity augments the fitness of a population with endemic malaria through its effect on the alpha thalassemia allele. In other words, if you don't have access to modern health care, it's a good idea to reproduce with your sister. That way your kids won't get malaria, though they may die of other things. I don't doubt that genetically this is very true. It's just creepy. In another study which proves that there is no field as cool as infectious diseases. This was published in Emerging Infections. What they did is they took some ancient mummies. These were 4,000-year-old mummy tissues. And they had 91 bone tissue specimens from Egyptian mummies and skeletons. Okay, 4,000-year-old bones, right? They found unambiguously Plasmodium falciparum DNA in 2 of 91 mummies. Now, that is cool. Doing DNA analysis of 4,000-year-old corpses and finding out they had malaria. That is just neat. Why only 2 of 91? Well, I suppose them pharaohs were inbreeding, so they were more resistant to malaria. You know what? Inappropriate joke time. Do you know what a girl from fill in your favorite state says when she loses her virginity? Get off me, Paul, you're crushing my cigarettes. But preventing malaria. I'm sure I'll hear from somebody on that one, but what other podcast gives you such classy humor as part of your medical education? Just the Puscast. 29 minutes and 1 second. I'm keeping to my goal of doing this in under a half an hour. A lightning fast Puscast, a review of the infectious disease literature and commentary. References, as always, are available on the website and link to the PubMed abstract. This has been brought to you by Pusware LLC, the publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion, your uber-hyperlinked electronic guide to infectious diseases at pusware.com. Now that you've listened to this nonsense, it is CME accredited. That's continuing medical education. Listen, get the online quiz, and get a half an hour free continuing medical education thanks to Legacy Health Systems. As always, I take this opportunity to plug the Quackcast, a skeptical review of supplements, complementary and alternative medicine, also available on iTunes, and of course my occasional contributions to the Science-Based Medicine blog. If you are a medical student and want to become a resident in internal medicine, remember, if Legacy Health System tolerates me, they may put up with your quirks as well. Bandwidth ain't free, so feel free to purchase this compendium and support the Puscast. Copyright by the Creative Commons license, www.creativecommons.org. The music is my son when he was 12 years old, improvising on the guitar. Be sure to go to iTunes and continue to feed my voracious ego with 5-star reviews. My 11-year-old keeps track of these, and it makes him very proud that his father is known all over the world. Oh, I'm so special. And as always, thank you for this most interesting consultation on allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, Goodbye.